Consider this USMLE-style vignette. A 45-year-old male presents with dyspnea, chest pain exacerbated by recumbency, a low-grade fever, and a pericardial friction rub on auscultation. Physical examination reveals jugular venous distension, yet the lung fields remain clear. This profile strongly hints at pericarditis, with an associated effusion, a textbook case, primed for your STEP exams. For Step 1, grasp the pathophysiology. Fluid in the pericardial space disrupts normal cardiac mechanics. Step 2 shifts focus to diagnostics, where echocardiography reigns supreme, displaying a distinctive echo-free zone encircling the heart. A chest X-ray might reveal an enlarged cardiac silhouette, often described as a water bottle shape in significant effusions, proof that medicine occasionally borrows from the beverage industry. Electrocardiogram (EKG) findings include low-voltage QRS complexes and electrical alternans, where QRS amplitude fluctuates with each beat. In cases of tamponade, memorize Beck's triad: hypotension, muffled heart sounds, and jugular venous distension. For Step 1 enthusiasts, note that tamponade compromises diastolic filling, slashing cardiac output. Essential USMLE keywords include pulsus paradoxus, echocardiography, and tamponade, terms that could be your lifeline on test day. Management hinges on the effusion's severity. Small, hemodynamically stable effusions may warrant only vigilant observation. However, for substantial effusions or tamponade, Step 3 prioritizes pericardiocentesis, the urgent drainage of pericardial fluid. In recurrent cases, a pericardial window, a more permanent solution, may be indicated. Equally critical is pinpointing the etiology, be it infectious, autoimmune, or otherwise, to guide therapy. For effusions tied to pericarditis, NSAIDs and colchicine often suffice, calming inflammation with pharmaceutical finesse. The mantra here is clear: detect promptly, intervene decisively, and treat the underlying cause. Armed with this knowledge, you're prepared to excel on your USMLE and manage pericardial effusion with confidence in clinical practice.